Good morning. My name is Mary Zanarini, and today I'm going to be talking about the U.S. perspective. And when I asked Perry about what, she said, oh, whatever. And okay. And so I asked Anthony Bateman, and he said, well, he's going to be talking about sort of the guidelines in Britain for the treatment of borderline personality disorder. So this talk is sort of about the U.S. guidelines and what I think might be coming up in the future or should be coming up in the future. Now, our existing guidelines were developed almost 10 years ago. And the chair of the committee was John Oldham, now of Menningers, and the members were Glenn Gabbard, also of Menningers, Marcia Goyne, John Gunderson of McLean, Paul Soloff of Pittsburgh, David Spiegel of Stanford, Michael Stone of Columbia, and Catherine Phillips of Brown. Now, the good news is that we had recommendations. The bad news is that they're now quite out of date. The recommendations were that individual therapy is the primary treatment for BPD, and I don't disagree with this. I agree with this. And that the initial medications aimed at different symptoms of BPD were an SSRI should be the first medication for affective dysregulation, an SSRI should be the first medication for impulsivity, and low-dose neuroleptics should be the first medication for cognitive symptoms. The problem is that this very careful and important synthesis of existing knowledge was formulated right before the publication of a large, by BPD standards, body of new studies concerning therapy and pharmacotherapy for BPD. At that time, only DBT was evidence-based, and there was a discussion of psychodynamic therapy not particularly well described because there weren't any studies about it. And the medication algorithms, which I was thinking of showing you one of the diagrams from the guideline, consistently led to aggressive polypharmacy with no evidence base. They were simply massive. Start here. If this doesn't work, add this. If this doesn't work, add this. And so you ended up with a person on 4 or 5 medications if they were treatment resistant, which many of these patients are. Now, what are our evidence-based treatments? The best known is Marshall Linehan's dialectical behavioral therapy, DBT. Also well known, or getting better known, on this side of the Atlantic is Anthony Bateman and Peter Fonagy's mentalization-based treatment, or MBT. There's also the schema-focused therapy, SFT, of Jeffrey Young in a study by Geese and Blue, and transference-focused psychotherapy, or TFP, which I believe was really the precursor to the psychodynamic therapy they were talking about in the U.S. guidelines. They were really developed in the late 1990s, and that's a series of studies by Clarkin, Kernberg, and Levy. Now, adjunctive treatments have come into being. The best known is STEPS. STEPS is a cognitive behavioral group treatment of 20 sessions in length, and STEP stands for Systems Training for Emotional Predictability and Problem Solving, and this is a treatment developed by Nancy Bloom and Don Black, and has been shown to be a good adjunctive treatment, although it did not show positive effects for self-mutilation and suicidality. There are also 3 treatments that have come out of McLean that are in their early stages. One is a manual-assisted cognitive therapy, MCMACT. This is for self-mutilation, by Igor Weinberg and John Gunderson. Another treatment by Kim Gratz and John Gunderson from McLean. Kim is now at the University of Mississippi, and this is an acceptance-based emotion regulation group strategy for self-mutilation, and then psychoeducation for borderline patients. And my colleague on that was Francis Frankenberg. And in that study, what we did is discover that simply giving people a workshop on BPD led by research assistants, guided by PowerPoint slides, but they had lots of other information to impart, allowed people the young women who were recently diagnosed with BPD, immediately got this treatment, had far greater decline, significantly greater declines in their impulsivity and in the storminess of their relationships than similar young women who got the borderline diagnosis but waited 12 weeks for this treatment, so that in many ways it's a possibly successful form of early therapy or pre-therapy, and in many ways might be used to plug gaps in many situations where people go to clinics and that doctor is not available. No one's available for 3 months. Now, controlled medication studies. There have been 14 or 15 of these since these guidelines were published, and these second-generation studies were about second-generation medications, antidepressants, mood stabilizers, and antipsychotics. And they've all been shown to take the edge off of BPD, and interestingly enough, often for similar symptoms. But none are curative. And you might say, well, that's bad news. Well, the good news, or a funny way of thinking about it, is that the medications for major depression, bipolar disorder, and schizophrenia aren't nearly as good as the happy ads on TV would lead you to believe. Just take a little bit of Abilify and you get a trip to the beach and a boyfriend who's really supportive. It's just not true. The bad news about most of these medications, not all, but most, are that they've been associated with substantial weight gain, I should say really huge weight gain. Not in the controlled studies, let me back that up, but when they're used by clinicians in standard practice. In the controlled studies, the weight gain is not that bad because they're only used one medication at a time. And there are other side effects as well, and they typically are the side effects associated with obesity. Now, other medication findings. My colleague Francis Frankenberg and I have conducted what turns out to be the only study of monotherapy versus polypharmacy, and not so surprising, we found that monotherapy is just as effective as polypharmacy. We also found in another study that omega-3 fatty acids are just about as effective as commercial mood stabilizers with no side effects and less cost, and also less stigma. Nobody minds taking an omega-3 fatty acid pill at work as opposed to taking Lamictal at work where you might have to explain yourself. So there have also been family therapies. There are multiple family groups treatment by John Gunderson and McLean, where what he discovered was when multiple families got together, it might not have helped the patient so much, but it sure helped the family members because they learned how to support one another. And Perry Hoffman's Family Connections program, which I think we might hear more about as the conference rolls on, which has been widely successful and has numerous people trained to provide this. Now let's talk about competition or consensus. This is, after all, science, and not everyone is in it just to be generous. The four main psychotherapies do share many features, and the results of these trials suggest good results if a therapy, and I'm really paraphrasing Anthony Bateman, has a reasonable intellectual foundation, is carried out by reasonable people, and in a reasonably consistent manner. So if it's well thought out, the people have good boundaries and are kind but firm, and if they're really devoted to a model and they keep to the model, these patients seem to do well. And I think getting to the competition part, it's a complete waste of time, either intellectually or for NIMH to get involved in this, trying to determine which of the big four is best. I know it gets people's juices flowing and this and that, but the reality is each may be best for different patients and different therapists. And it's wonderful that we now have a range of treatments that might fit different patients' personalities better and might fit different therapists' personalities better. And we also need to remember that each may also be better than others for different times in the course of a patient's life journey. It's possible that CBT-like treatments, DBT, are better when people are very actively self-destructive, but other more psychodynamic treatments may be more useful when people are somewhat more calm later on. This is just a thought. Now, the reality check is that most patients will not receive any form of evidence-based treatment. These forms of treatment, even DBT, have not really penetrated the mental health system very deeply. And the reason is cost. Even at McLean, we don't actually have a full-scale DBT program because we can't afford it. That we have DBT-like groups, but we can't afford the whole paradigm of individual therapy as well. And I would guess that's true in most places. And it's certainly true in people's private practices. They just can't come up with these complex treatments. And I'd suggest if a patient is mildly to moderately ill, and many borderline patients are not catastrophically ill, they may not need it. But they would certainly benefit by having an informed therapy where the therapist actually has learned the essentials of each of these forms of treatment, thought about it, and come up with his or her therapy that's probably partially cognitive and partially psychodynamic. Just doing whatever with these patients isn't useful, but feeling devastated that you can't provide a complex treatment that requires all kinds of moving components is, I think, not a reason to beat yourself up. Now, what are the goals of therapy? Obviously, they're to feel better, they're to function better, and to understand oneself better. Now, let's have models of therapy. The model I believe in is that therapy is an adjunct to life, and the purpose is to facilitate enough change that the patient is open to the reparations of adult life. I think we all, in the end, get more out of marrying a more mature partner than we do that extra therapy session, and finding work that is a source of pride and esteem. And I often tell my patients, and I just discovered that John Gunderson now tells his patients, get a life. And this is often greeted with amazement and astonishment, slamming doors and leaving, but curiosity and coming back about 10 minutes later and saying, really, sadly, do you think I can have one? Do you think I can make a friend? Do you think I can date? Do you think I can have a job? The other model of therapy, which is common in some circles and certainly common in Boston, is that therapy is a lifestyle. Its purpose is to process and understand every event and every relationship. And if you're not seeing a patient 3 to 4 or 5 times a week for 10 years, it's a devastating kind of disappointment for the therapist. Needless to say, not many patients can afford this, but it is intriguing to watch this. Now, what are the impediments to treatment? And I'm rocketing along because I want to leave time for questions. 40 million Americans have absolutely no health insurance, and that's a real impediment. You cannot get psychotherapy in an emergency room. You can barely get an aspirin. Parity bills, whether it's the US one or the one we have in Massachusetts, typically do not cover BPD, which forces therapists to say that patients have depression, bipolar disorder, or an eating disorder. They're putting every single thing down there, and what this leads to is they don't actually tell their patients they have BPD, and they don't actually tell them what that means, and that it's a good prognosis diagnosis, as you'll learn tomorrow. And we also find that mental health benefits are managed in some way, and I don't think the parity bill will change this. And they strongly encourage the use of medication, including expensive newer medications. Often the reviewers for insurance companies will be happy to agree over time to give somebody with BPD 5 different medications, and that's a common cocktail that patients come into McLean with. They're on a second-generation antipsychotic, they're on an SSRI, they're on a mood stabilizer, they're on an anxiolytic, they're on a stimulant, and you wonder how they can even speak, let alone function. They've gained 40, 50, 60 pounds, and we're told that these medications are keeping them alive, but yet what you'll find tomorrow is that in this longitudinal study I've been conducting of severely ill people who are initially inpatients, the suicide rate is 4%. It's not phenomenally high. So I think it's something to think about. My personal experience is that psychopharmacologists certainly are often wonderful people, mean well, but when you see somebody once a month or 3 times a year, you rely on that person's therapist if they even have one, and you might feel compelled for a variety of reasons to add medications. For example, we obviously have the advantage of charts, and I'll work with residents and say to them, you know, this patient over the time she's been treated at McLean has gained 80 pounds, and he'll say she was always fat. And I'll say, what do you mean she was always fat? I knew her 10 years ago and you were in college. And they'll say, well, you're wrong. We'll get out the chart, and we'll be like, oh, well, so she was 115 pounds then. So what do you think happened? And then you start the dialogue. It's like, you know, what is the purpose of this? She needs them all. And it turns out what she really needs is she's attached to you. And you could give her karaoke lessons, and she'd be doing just as well. And let me be a little more serious. Let's talk about new foci for treatment. Most of the treatments for BPD that I've outlined are aimed at what I call their acute symptoms. And those are symptoms like self-mutilation, suicide attempts, stormy relationships, the dramatic symptoms of BPD. And it turns out these are the symptoms that resolve the most quickly. We need treatments that are aimed at temperamental symptoms such as undue dependency, fearfulness, abandonment concerns, the quieter symptoms of BPD that don't resolve as fast, but that we don't really have treatments for. We often notice these things about people and just pray to God they'll go away, the symptom or the patient, depending on how you look at it. But what we might need, they might need, is coaching to accept these problems as somewhat chronic and to learn how to get around them. In other words, strategies for normalizing temperamental issues. So you're shy. Lots of people are shy. This kind of thing, it's not the most devastating thing that can happen. I often say to patients, you know, you talk about being, for example, shy as though it's a federal crime or you might be arrested for it. And people often do hold these symptoms as their secrets, the things that trouble them the most. They're actually not that concerned about things like self-mutilation or suicide attempts because they do them somewhat sporadically and often stop them in the first few months of some kind of containing therapy. Patients often need strategies for successful adaptation to these symptoms. You're shy, so how can you get around it? How do people make friends? And I think sometimes people feel that these kinds of activities in therapy are not worth their time, they're beneath them. I think they're not beneath anybody and are absolutely essential. Something else is that patients need help in the social realm. They often don't know the answers to these simple questions or ideas, how to make and keep friends. They used to have friends, but now they don't. When they're put on an inpatient unit, they take the names and emails of people, their phone numbers, and then don't know how to keep in touch with them. They don't know how to initiate and manage romantic relationships. I was sexually abused. Can I ever date? Am I too damaged? Will somebody know I've been sexually abused? What will happen if I try to have sex? And then how to repair family relationships and or gain greater autonomy from parents. I see the families of every single patient I see, and I see them not so much in, I guess it is family therapy, but it's once a month. And in that treatment, the patient tells the parents things they want them to know. It's their choice what they tell them, and then we work on that. And parents often take real heart from that kind of sharing. They feel valued. I had one mother saying to me with a wink, "Why don't you tell me the truth? I think I'm the best patient you've ever had. I really have learned your philosophy better than anyone else." And I thought to myself, you know, that's true. Still other points we could focus on. I think a lot of these patients need vocational counseling. How do you look for a job? How do you behave in a job interview? How to handle going to work when tired or upset, which is a big one. If it's raining outside, you can still go to work. If you haven't slept, you can still get to your job. If you're devastated, what skills can you learn so that you can manage it? Because you'd be surprised at your coworkers who are usually, particularly as they get older, are exhausted, disheveled, and hanging on the side of their desk as well. People are not bouncing into work as happy campers. They're often crawling, dragging themselves in. The point is to get in on time, look reasonably clean, and stay awake. And then another big one for borderline patients is how to manage conflict at work. I had one patient who was the administrative assistant to the CEO of a major international corporation. And when she got really angry at him one day, she said to him, and this is almost unbelievable when I think about it, "Now I know why your first wife killed herself." And she had no idea that this was over the top and why he called security, put her plant in a box, and said goodbye. And she just reached into some place of deep ugliness and came out with this, and she really needed to learn to think about that kind of stuff. These patients often need life coaches. I often hire mental health workers at the hospital to help people learn to use public transportation, how to budget, how to go to the bank, how to shop for groceries, clean their home, do laundry. You can also talk with people. I would not have mental health workers necessarily deal with these issues. Personal hygiene. How often do most people bathe? Sleep problems. I used to have patients call me at 3 in the morning and say, "I'm fighting with my boyfriend." And eventually I learned to say, "What are you doing up at 3 in the morning?" And it's often a news flash to borderline patients, like other patients, or just young people in general, that it's better to go to sleep at around 11 And so to schedule 8 to 11 for the fights, not 1 to 3 or 1 to 4, and then call your therapist. Issues with physical pain. Often these people are very sensitive to physical pain, and the real issue, I think, is sometimes they really are in physical pain, and sometimes this is a sort of segue from their emotional pain. I think the hallmark of borderline patients is not any of the particular symptoms as much as their tremendous inner pain and the fact that they have what I call a hyperbolic temperament. They need to share that pain with others and get them to acknowledge it, which can be stressful and also can be helpful. Psychotropic meds, I think absolutely people with BPD need to be medicated if they're suffering from a clear-cut comorbid condition that's been shown to be effective. One of the reasons I think patients with BPD often don't respond as well to meds with their comorbid condition is they don't quite have the same comorbid condition that the people with simply that comorbid condition have. For example, I think a lot of borderline patients are medicated for a depression they don't have. They have chronic dysphoria and unhappiness, which is not going to yield to medication. And in other cases, as like the one I've just mentioned, we need to use restraint in medication. And remember that borderline patients are often unhappy and functioning poorly, and it would be helpful if doctors said things like, these meds will not give you friends or a job, but if you get someone or something in your life, you will feel better. I think therapists also need to take this stance. Medications are expensive, they have side effects, and they make people in some ways lose their sense of efficacy, that they're not in control of their life. Somebody's going to give them something and they're going to feel better. I would suggest only using one medication at a time if you want to help someone decrease the severity of their BPD symptoms or associated symptoms. I'm not opposed, as the English guidelines we'll hear about soon, to giving somebody one medication if it's well chosen and if we're clear that it will only help a little. We need to have a discussion. You're not going to take this pill and dance out of here. You're going to feel a little bit better. And I'm also only going to give it to you for a limited amount of time. It's not going to become a lifetime experience for you. We need to pay, doctors need to pay, and therapists need to pay much more attention to side effects and the long-term health effects of standing meds. And let's remember that obesity is not a worthy treatment goal, and that in fact this happens to people in clinical practice all the time. And it's going to be much harder for people to get a good job, date, have friends if they are obese, not to mention their health. In my longitudinal study, we're losing more subjects to death from obesity-related illnesses than we are to suicide. And I think that's something really to think about. Now, clinicians, typically in the U.S., meds are prescribed by a psychiatrist or a primary care doctor, and we may need to use nurse clinicians more widely. And in fact, if it's monotherapy, I think this would be a good choice. And typically, therapy is provided by a psychiatrist, a doctoral level psychologist, or a social worker, and we may need to use master's level counselors and even BA level counselors, people who can be trained to do these forms of therapy and who are people who are well put together themselves and are not going to do inappropriate things with patients, either things that are too loving or things that are too hostile. I was struck, for example, in the STEP study that although it was an adjunctive group therapy, most of the patients were on meds, but very few were actually in therapy. So it really wasn't adjunctive to something else of a psychosocial nature. Now, newer self-pay initiatives, you might regard these as sort of dream experiences. At McLean, we've just opened, well, a year ago we opened a DBT-based unit for adolescents with BPD. They can stay 4 to 6 weeks. And we're soon to open a step-down program for longer stays. We found that kids get better, but they need to stay there for a more extended time. And we're in February going to open sort of a MBT cognitive treatment as well, based unit for adults with BPD with a 4 to 6 months expected length of stay. These are ideals, but these are self-pay, and this is for a tiny, tiny slice of people. Most of us don't work in these settings. I actually don't work in this part of McLean, and that we really need to come up with things. And most of my suggestions are around avenues that patients with average insurance or even no insurance can deal with. Now, going forward, we need new treatment guidelines. The guidelines are about 10 years old, and all of these new developments should be taken into account. And we need more funding for treatment research. In NIMH's desperation with a limited budget that actually is going down in value every year, important research moving from efficacy studies in medical school settings to effectiveness trials in the community, they're not being funded because they can't afford to. Now, suggested research, we need to develop and study cost-effective treatments. Such treatments could be adjunctive in nature or standalone, and they can be discrete modules aimed at specific symptoms, or they can be part of a multifaceted treatment that is phased in as needed. I don't think we really know very much about these short treatments and whether the improvement patients make is long-lasting, but I wouldn't rule them out of hand. And in conclusion, I think BPD is a highly treatable disorder, but the results of all of this research are far more important than winning closely argued points. People fighting about psychodynamic treatment versus CBT-based treatment is old hat, it's old news, and it's time to stop it. So thank you very much. Okay. Do you have a complete reference list for studies that you've described? Yes, if you email me at zanarini@mclean.harvard.edu, I can send you reference lists. And which medications best target chronic fearfulness? I don't think any medications target fearfulness. Medications are meant for anxiety, which is a free-floating form of physical arousal. Basically, fearfulness might be due to a trauma history of some sort, and people are afraid of being harmed again. And that really cries out for, I think, some sort of support and some sort of cognitive map as to what's going on. We always want in our society to reach for medications, but I think reaching for a therapist might be a better idea. What food supplements contain omega-3 fatty acids? The kind of omega-3 fatty acids we used were pharmaceutical grade. I wouldn't want to recommend anything in your health food store because they actually come with all kinds of additional things put in there that may not be good for your health. I think the hope for treatments like omega-3 fatty acids is for them to be produced at a pharmaceutical grade. When do you expect new U.S. guidelines for meds? I don't know. DSM-5 is out supposedly in 2011. I don't think the guidelines would be written until after that because the disorder may be redefined in some way. What did you mean obesity is a worthy treatment goal? It's not a worthy treatment goal. Gender differences, male-female. Studies of patients always show that 75% of those with BPD are female. Studies in the general population show that it's a 50-50 proposition. This one is one about someone's particular med situation, and if you'd like to talk to me about that later. What's the effectiveness of DBT when it's not the total package? People typically don't study that. Many people, Marcia's DBT has had the most research done on it by far. And the VA, for example, has changed it a bit and shown it to be effective. But just having the groups without individual therapy, I'm not sure it's been studied. It might have been, so I really can't say. And how can family members help an adult family member who's obese and seems to eat to cope with emotional pain? That's tough. I guess what I would do is encourage somebody to go to Weight Watchers. I think self-help groups with other self-confessed sinners is the best way to go. Whether your relative is eating because meds have changed her appetite or her metabolism, I don't know. But the goal is to lose weight, and I think being surrounded by people who are unhappy but are taking a practical approach would be a good idea. How do you wean off current meds? I think that's something for each patient and his or her doctor. It should be a mutual decision. Which of these medications do you guess is helping the least? Because who can know if you're on 5 or 6 what's doing what? And slowly to go off them one at a time in some way that each of you feels is good. BPD is such an inappropriate name. Are there any other name options? People are mentioning other things, emotion dysregulation disorder. I keep suggesting mercurial disorder, but I seem to be the only person who likes it. But I think it's spiffy, and it doesn't sound so sick. It just describes, I think, the patients well. Omega-3 fatty acids, documentation to support using this instead of antidepressants. I don't think it should be used instead of antidepressants as much as it does help a bit with lability. It might help a bit with depression as well, but again, something like omega-3 fatty acids is meant for outpatients with BPD, people with mild or moderate cases. I'm not suggesting it's for use with desperately ill people who are in the hospital. But all I am suggesting is that by the time somebody's on 5 or 6 meds, you cannot possibly know which of these meds is useful. The person is not only gaining weight probably, but it's enormously expensive. Some of these pills are $8 and $10 a pill. And when you think about it, it's amazing to me. I'm always amazed that insurance companies will pay hundreds and hundreds of dollars a week for medication, but begrudge the patient one therapy session a week that probably costs about $100 for most insurance companies. So that seems uniquely puzzling and something for advocates to really go after. Okay. It's impossible right now to attain pharmaceutical grade omega-3s because the company is no longer in business. And can a reasonably intelligent family member learn enough about BPD to be helpful to a family member, adult who seems to have BPD has not been diagnosed? Yes, you can. You can use the same techniques the therapists do, which are clarification and confrontation. Clarifications are simply when somebody says, you're a complete jerk. You can say something like, it must be hard to spend time with me when I'm just so disappointing and so unhelpful. And it's like translating a language, because I think that's what the person thought they were saying, so you might as well reflect back to them what they wanted to say. And confrontation doesn't mean, you're a bad person, blah, blah, blah. That's out of control confrontation. But it can be humor, it can be a raised eyebrow. I remember when I was a teenager and I came home from college and I didn't have a summer job between my freshman and sophomore years, and I was looking through the want ads and saying no, no, no to everything. My father somewhat humorously said to me, gee, it's too bad the 2 Senate seats in Massachusetts are filled. And I really clearly got his message, and I went to the local country club and I was a lifeguard. So thank you very much.